Yeah, we can start. Good evening, everyone. It gives me great pleasure to be here to start this new version. I mean, something very unique, which has not been attempted before, the Clinicopathological Conference. One of the presidential action plans of our President, Dr. Balashankar sir. We'll start today's program with the pediatrician's prayer by our academic coordinator, Dr. Murugesh Lakshman. Over to Dr. Murugesh Lakshman.
Good evening. Grant us the quality of holistic healing. May we humbly realize how privileged we are being bestowed with the ability to alleviate suffering. May we be emissaries of health, learning, charity, love, and peace to all children and their families, irrespective of status and creed. Give us the wisdom, understanding to change the things we can, retain the good and accept within reason the things we cannot change. Grant us your blessings, grace and mercy in all situations, at all times, and amidst all people. Thank you.
Thank you very much, sir. We have always attempted to expand our learning and knowledge with the digital platform. And more
you are not audible.
I think Dr. Balashankar sir, our president, thought about going in depth about a particular case, which is something which we haven't done so far. So I request our president, Dr. Balashankar sir, to inaugurate the session.
Thank you, Tirumuran. Thank you, Murugesh Lakshmanan, for bringing this program into the teaching programs of IAP Tamil Nadu State. And I should thank Dr. Ashwath, first of all, who accepted to do this clinicopathological conference. Actually, I was fond of listening to this Massachusetts case, university case studies that was done during my undergraduate days by our teachers. Actually, they will present to some extent, then ask what is the possible diagnosis. Then they will go to the clinical findings, then discuss what is possible, then investigation at that level, and then surgery, biopsy, and all. It goes on like that. And at last, the diagnosis will be one thing which will be surprising to everybody. That is how it will be there. That case studies, Massachusetts case studies. Like that, we have conducted in Madurai also 1 or 2 clinicopathological conferences when I was doing as assistant professor. Some 4 or 5 we conducted. Some or other, then it got dropped out. It is one of the very what can I say? Very important and very in-depth analyzing case discussion. Actually, well, that's what I can say. When I told Dr. Ashwath to be the coordinator for this, he happily accepted. Actually, then now this is the first time after 6 months. This is the first thing, and probably in the coming months we'll be able to do 2-3 more within this year. That's what I honestly feel. Once again, I thank Dr. Ashwath for bringing in this CPC for learning, and I should thank Dr. N.K. Subramanian sir, who accepted to be the expert discussant pulmonologist. And thank you, Dr. Kannan, for Kannan radiologist, Rajeshwari pathologist, and Renuga, who is the presenter today. I hope we'll all have a fantastic learning experience today. Thank you very much for the opportunity.
Thank you.
Thank you, sir. Thank you very much, sir. Now I request our academic coordinator, Dr. Murugesh Lakshman, to introduce the experts for today's session and then proceed with the session.
Good evening. So before going into that, actually this clinicopathology conference which we are hosting for the first time is actually a brainchild of Balashankar sir. Even in our department, they used to frequently say you should conduct it. Conduct PG conduct. So for the postgraduate who are unaware what is clinicopathological conference, once again a brief introduction about it. It primarily relies on a case method of teaching medicine. It's a teaching tool that illustrates the logical consideration of differential diagnosis, which is used to evaluate the patients. The whole process involves presentation of a case by a presenter, and also again with the diagnostic details and the investigation details, and then the discussion of the differential diagnosis by the panel of experts, and logically narrowing to the list of a few probable diagnoses, and eventually reaching a final diagnosis, which will be confirmed once again by the presenter. As Sir told, the idea first practice in Boston back in more than 100 years back, 1900, by hardware internist Richard Cabot. So the advent of this, all the information technology and other things, CPC has fallen to, lost its popularity probably, but still a well-presented CPC remains a dynamic tool of teaching that not only offers a clinicopathological correlation, but also to build a clinicopathological competence. So introducing the speakers. Just 1 minute. Let's share this. Just the screen visible, sir?
Yes, yes.
Okay. So the lead moderator will be Dr. Ashwath, sir.
Yes, yes, yes.
Coimbatore, pediatrician Coimbatore. Experts will be pulmonologist Professor Subramania NK. He is a medical superintendent and professor of pediatrics, PES Institute of Medical Sciences and Research at Kuppam. He is a past chairperson and secretary IAP National Respiratory Chapter and vice president IAP South Zone 2022. The radiology expert will be Dr. Kannan Gunasegaran. He is a lead consultant pediatric radiology at KMCH Coimbatore. And the pathology specialist will be Dr. Rajeshwari, who has a very special interest in oncopathology. And over to today's moderator, Dr. Ashwath, to take over the proceedings.
Thank you, Dr. Murugesh. I think enough introductions have been made to the whole process. It's a novel venture and is the brainchild of Professor Balashankar sir. We have tried to put up a fairly impressive set of slides to make it more interactive, educative, and we hope this will be a very useful learning experience. May I request Dr. Renuka to start presenting. As she presents, we'll take frequent pauses to discuss various aspects of the child's case history as the case unfolds. We will have the pleasure of having a very, very eminent pediatric pulmonologist in the form of Dr. Subramania, whose sense of humor and incisive comments and astuteness is a treat. And then we have also the benefit of Dr. Kannan, who's a very, very vital link in our chain of command in KMCH and provides valuable inputs in the field of pediatric radiology, whichever aspect of pediatric imaging it is. And then we have Dr. our pathologist, Dr. Rajeshwari, who's been instrumental in the working up of this case. So when she says anything about this case scenario, she knows what she's talking about because she has actually been involved in the working up of the case. Over to you, Ma, Dr. Renuka. Please go to slide share mode.
Shall I start still?
Yes.
Good evening, everyone. First, I would like to thank Dr. Ashwath sir for giving me this opportunity. We will start with the case presentations. Master M, a 16-year-old adolescent boy, first born to non-consanguineous parents, who is the resident of Normacal, informed his mother and her reliability is good. He brought with the chief complaints of cough for 4 days, history of low-grade intermittent fever for 3 days, history of headache for 2 days, and history of vomiting for 1 day. Coming to the history of presenting illness, he was apparently well till 4 days back. Then he developed a history of cough since last 4 days, which is productive cough with white to yellowish sputum, which is non-foul smelling and not associated with any blood in sputum. There is no aggravating or relieving factors. There is no diurnal or postural variation. History of fever for 3 days, which is low-grade intermittent fever, not associated with rash, chills, or rigor. History of headache for 2 days, which is bifrontal headache, which is dull aching and there is no diurnal variation. History of vomiting for 1 day, 2 to 3 episodes per day, which is non-bilious, non-blood-stained and non-projectile vomiting. There is no history of upper respiratory symptoms like sneezing, nasal discharge or sore throat. There is no history of fast breathing or any breathing difficulty or noisy breathing. There is no chest pain or hemoptysis and there is no photophobia or neck pain. And there is also no history of loose stools or abdominal pain. Coming to past history, he had a history of viral fever 3 months back and treated as wheeze-associated lower respiratory tract infection on OPD basis with nebulization. And history of dengue 3 years back, and there is no history of recurrent respiratory tract infection. There is no history of frequent nebulization. There is no history of contact with tuberculosis. Coming to family history, he is a firstborn to non-consanguineous parents. There is no history of similar illness in the family members. Neonatal period was uneventful, developmentally normal child, and he is immunized up to according to the IAP schedule. On general examinations.
You told something like concerned with the neck pain or something you told. What is it? In the present illness.
He had a fever with headache and vomiting, sir. So
you can go back over something was peculiar in the history. Present illness.
yes.
Present illness. I think photophobia. What is that photophobia, neck pain? Oh, meningitis ka getting la.
Headache, vomiting.
History of headache, vomiting, fever.
Can I come in?
Okay.
Renuka, can you go from the first slide? We'll finish off this history.
Yes.
Yes, sir.
Because before we go for examination, can you go for the complaints?
Yes.
Now,
Yes, sir.
basically, this patient is a 16-year-old. So therefore, we should all come out of the mindset of the pediatrician first. And then we should not be thinking of any of the childhood illnesses in that sense. What I meant was like any of those neonatal, post-neonatal, infantile, under 5, and so on and so forth. All those causes should be out of our mind when we are discussing 16-year-old. I'm just for the benefit of audience, I'm just making it clear. So you must come to the mindset of a typical physician's approach than a pediatrician's approach as far as this case is concerned. I think all of you agree with me on this point. Now,
yes,
the second point is that this patient had cough. Now, and then there is a fever and headache and vomiting. Now here, you see these are the 4 positive symptoms. Let me not go to the symptoms that are not present. If you look at the cough, it can be because of upper airway, lower airway. It can be because of the parenchymal diseases, interstitial diseases, pleural, remote diseases, extra pulmonary manifestations, which can also cause cough. Let us keep that in mind. Now, if you look at the age group of presentation, 16 years, and if somebody comes with a cough, I would even go to the extent of looking at something like adult diagnosis, like bronchitis, which are quite common, but not as common in a pediatric age group that we would see. It could be smoking, teenager, we will never know, and exposures, all these factors, or even allergic causes, infective causes, so on and so forth. Now, there is a fever. So therefore, let us look at inflammation. And is it infection? And if so, what type of infection? Now, if you take the combination of cough and fever, and now that the cough is productive, if the cough becomes productive, remember that the mucociliary epithelium has some issues and there is a hypersecretion in the airways, or there is responsive secretion, or there is some necrosis or inflammatory exudate that is coming out, and therefore the sputum has become productive. Am I clear? So therefore, when you come to a wet cough, I'm really interested to know, with a history of only 4 days and a wet cough,
I will narrow it down to something like a suppuration that is happening on a really acute basis that must be causing the productive cough, or it could be a flare-up of a pre-existing chronic illness. So these are the two possibilities that come to my mind. Which one shall I think of right now? If you look at the fever, and if the fever is low grade and intermittent, that means to say, for me, the second possibility, like flare-up of a pre-existing disease, is more likely than an acute disease. And can I have in the chat box, a chat box or somewhere, reactions? Do you all agree? You can just put, thumbs up or something that, you are all in agreement with the process of thinking, thought process. Basically, this is wonderful to see a combination of a productive cough and a low-grade fever. It is not productive cough. I'll keep this 3 or 4 combinations for a dry cough and a high grade fever, wet cough and a high grade fever, wet cough and a low grade fever, and wet cough and a high grade fever. Are you getting my point? If you just it's not about micro dissection, but at least at this stage, if you look at the fever and the cough combination, if at all, if it is pneumonia, let me go straight away to the most common things that are presentable. And if pneumonia, then what type of pneumonia it can be? From the history perspective, is that it has to be some atypical organisms straight away. I'm because at this age of more than 5 years of age, it can be viral or atypical. Viral, Dr. Palinaraman, excellent point. I agree. So now it looks like, probably we can have viral, but absence of prodrome, etc. That's fine. Headache and vomiting are there simultaneously in this patient, which has to be taken into consideration. There is some amount of toxicity and some amount of subtleness in the way that this patient is presenting. So therefore, I'll put these two diagnoses on top. Like, if at all I'm think of any suppuration, either a viral disease, which is not a suppuration, but because of headache and vomiting and a cough. But I'm yet to see, Palani, I think you would agree with me that wet cough and an atypical infection I have not seen. Most of it is a dry cough, wheeze, and a low-grade fever, some plus minus breathlessness, some effusions which are causing breathlessness. These are the types of presentation even in that atypical. But here you are looking at a wet coughs. Therefore, I'm coming closer to non-viral and probably atypical. Okay. Now, can it be early tuberculosis? Not waiting for, because every audience would ask this question, sir, we will be fooled later on when we send a wet cough for sputum examination. Can it be tuberculosis? Yes, it can be, but at this stage, no, because it is too early to bring in tuberculosis just for the sake of discussion. So if at all this child doesn't respond to antibiotics, I would keep all these points in mind, that it is not straightforward routine organisms, be atypical, be chronic like tuberculosis, or some other strange non-infectious cause. Therefore, the reason being non-infectious cause is for these reasons that a typical infection cannot be explained from this disease. This is all that I have to just take at this stage. Let me not go too much into it. Next slides, ma beta. Couple of slides. Let us quickly run through. Only as if I'm taking a pulmonology bias, for headache and vomiting, apart from an intracranial infection, I would also look at sinopulmonary. Sometimes sinusitis, if it is coexisting with a suppurative lung disease, it can also cause headaches. And one has to be little, descriptive in the type of the headache, because it is frontal, dull aching. Sometimes you will never know, and it can be. So just let's keep that in mind. It may or may not be related to that. Let's go for the examination later on. But just move on the slides. I'll not be going too much into it. Dissection of the symptoms. Past history, here only one point I wanted to know. But when you take the history of any, you have mentioned wheeze-associated lower respiratory tract infection. But I'm just, Renuka, beta, tell me, wheeze-associated lower respiratory tract infection is a diagnosis usually in preschool children. It's not a diagnosis to be labeled under in around 16 years of age, because wheeze is common in smaller airways in younger children. So therefore, if an adolescent has got a wheeze-associated lower respiratory tract infection, then I'm worried about the wheeze. Because wheeze due to an infection is because of mucosal edema, secretions, thickness, narrowing, which can happen age appropriately in young. And this is age inappropriate presentation. And therefore, I am worried if wheeze is because of an infection at this stage, number one. Second thing is, second point which I want to tell is that what happened with nebulization is what I wanted to know. Renuka, if you are handling this patient, what was the effect of nebulization? Was it relieving, not relieving? This is important for us. Whether if the information is available, well and good. If the information is not available, then also well and good. Please, I request all the pediatricians who do some nebulization on OPD basis, please auscultate again after nebulization. This we don't do as a practice, because if it relieves, then I have got something like reversibility of airflow obstruction, which is a very important point. And if it doesn't get relieved and remains status quo, that's a very, very important message for me that this wheeze is not because of smooth muscle obstruction, smooth muscle bronchospasm, or because of the edema and obstruction, which is typical of allergic diseases, which are very common nowadays. So now that you have given some no history of recurrent infections, nebulizations, and all those negative histories, I'll keep that all of them out, which I'm fine. I'm totally fine with keeping all of them out. And secondly, even a productive cough and a wheeze-associated lower respiratory tract infection doesn't go well with me. Are you getting my point? Productive cough this time, but just a kind of a wheeze-associated lower respiratory tract infection in the past. Now, when you say wheeze or lower respiratory tract infection, I just take the message that let's not worry about the nomenclature, but there was a wheeze and there was a lower respiratory tract infection. I'll take that message. Renuka, I'm correct? Yes. That much will take. Now here, I'm again further. I wanted to just tell you only one line message, which I was recently teaching some of my students, is that between the wheeze and the stridor, wheeze is high frequency sound and stridor is, a kind of low frequency sound. And the low frequency sounds travel longer and will be well heard. High frequency sounds are narrower and, will be heard short. So therefore, when a mother tells you some sound, it is more likely to be a stridor than a wheeze. Am I clear? When you auscultate, you will get definitely a wheeze. But audible wheeze means it is more likely that it is more proximal, because it is likely that it is not high frequency, but a low frequency kind of presentation. So these are very, very important for, these are some of the messages which I am saying. Renuka, can you give me some clinical inputs with the points that I discussed? Now I'll mute myself and I would just listen to you, because you are the person who was seeing this case, isn't it? Can you just give me some more things? How was the child looking? Was it sick looking or toxic but having low grade fever, or was it not sick looking, was fine? What kind of that goes to examination, but anyway, from the mother activities and playfulness and things like that, can you give me some more information?
He was not that much sick looking at the time of presentation, sir.
So that means to say, if we have, let's say, why I'm asking you this question is only because of two reasons, Renuka. Now here we have got headache and vomiting. Headache and vomiting, if in a background of infection, I will look at them as signs of toxicity, let us say. Headache, vomiting, sickness, febrile. You understand? If I take that as a sequence, the child is not that sick looking but has a headache and vomiting. That means I should look at something else for headache and vomiting, or this headache and vomiting may be disproportionate to the way that mother is presenting, but there is some link that is missing. Are you getting the point? There is a wet cough and there's a low grade fever and there is a set of headache and vomiting. There is some asynchrony or atypia, which can be either taken by an organism or by the presentation itself. So are we really correct in making a diagnosis of a simple day-to-day pneumonias that we are, bronchitis, pneumonia, infections that we are dealing with? These are the points that are out of the box for us at this stage. You can go further. I'll just not comment on any slide where there are no comments. Just move on. No comments on this in this slide. Next. We close the history at this stage. Now we can proceed. If there is anybody else wants to pass any comments, I'll just stay back.
Dr. Renuka, you can go ahead with the general examination findings.
On general examination, he is conscious oriented. There is no pallor, icterus, cyanosis, clubbing, or pedal edema or lymphadenopathy. Vitals on examination, he was febrile and he had a mild tachypnea. Hemodynamically, he is stable and he is maintaining saturation in room air. Anthropometry, he had a weight of 78.6 kg and height of 171 centimeter with BMI of 26.9, which comes under overweight. Coming to systemic examination, respiratory system. In upper respiratory tract, nasal cavity looks normal. There is no septal deviation or nasal polyp. There is no paranasal sinus tenderness. In throat, there is no tonsillar enlargement. Posterior pharyngeal wall looks normal. In ear, external auditory canal and tympanic membrane looks normal. Then on inspection, trachea appears to be in midline. Shape of the chest was normal and bilaterally symmetrical. Movement of the chest is equal on both sides. Apical impulse is not visible. There is no scars, sinuses, or dilated veins. On palpation, trachea confirmed to be in midline. Apical impulse felt at the left fifth intercostal space, medial to the midclavicular line. There is increase in vocal fremitus over the right inframammary and intra-axillary region. Coming to percussion, there is dull note over the right inframammary and intra-axillary region. Tidal percussion was normal. There is no shifting dullness. On auscultation, there is normal vesicular breath sounds heard in all areas except over the right infra-axillary region where bronchial breath sounds heard. And there is diminished intensity of breath sounds over the right inframammary and intra-axillary region. There is increase in vocal resonance in the right inframammary and intra-axillary region. Coming to other system, in CVS S1 Herd, there is no murmur. Abdomen soft, non-tender, no organomegaly. All quadrants moves equally with respiration. There is no sinus scars or dilated veins. CNS, there is no focal neurological deficit. Spine and cranium was normal.
Dr. Subramania, you want to question her on the examination findings, sir?
I'll come. Renuka, beta, just go by one slide on, just quickly on examination. First slide of examination. We have finished the history.
General examination.
Just go back. General examination, I don't find anything except that the child is not non-toxic, non-sick looking as much as we would expect.
Here.
And except that's enough. Upper respiratory, there is nothing contributory. Okay, I agree on that point that there is obesity. That's fine. Obesity is there, but what obesity can tell me is that probably there is no chronic illnesses that are going on in the child.
Absolutely.
In the past. That's all is what I still like say old bronchiectasis, tubercular, and some progressive diseases which I would be thinking of, which would affect the nutrition of the child, are unlikely. So therefore, any recent onset illnesses is what I should be looking for, or non-infectious illnesses, or those ones which doesn't produce this macrophage activation syndrome. So at this stage, upper respiratory, there's nothing much contributory. I would have looked for any evidence of atypical infections, like you may find air bubbles in the eardrum, or you could have found a tenderness on frontal sinuses, which I was expecting for headache and vomiting. These are negative, and they are very, very important findings for us. So that even at this stage, and the throat would also give a clue to the chest. When you have a wet cough, and you say pharynx is normal, now I'm little worried. That means to say they probably the origin of the whatever so-called infection or suppuration or wetness of the cough is not from the upper respiratory. This is an important point at this stage for me. And then that's a very important message because, sometimes pulmonary infections happen, or there's a postnasal drip, or there's a pharyngeal congestion or evidence for infection. And, concomitantly, if you have low respiratory symptoms, then you can relate it and probably make a wiser diagnosis, but it is not necessary. But I'm just trying to tell you that it is normal. That's the point to be noted. Next, Ma. In the respiratory system, see, when typically when you examine this adult type of examination, like shifts, change in the movements, apex normal, trachea central, all this only means that you don't have a gross mass effect. That's all. It doesn't rule out any disease. It doesn't rule in any disease. For example, you can have a collapse, but trachea is central. What I meant was if the collapse is small and subsegmental. What I meant. So therefore, for all the students who are watching or for the practicing pediatrician, these will only mediastinal pull-push syndromes or deviations that you would see on examination. In one line, I'll tell you, will only mean that there is no grossly large pathology that would cause these effects. However, they do not rule out anything. Now, if I come at this stage, there is an increased vocal fremitus. Probably VR in the next presentation, you told VR is also increased. So when we have VF, VR increased, then usually it is like causes are like pneumonia, cavities, or sometimes cysts which are, filled and resonant, so on and so forth. So the separation, etc. Separation sometimes getting opened up. All these are the causes of increased vocal fremitus. But at this stage, I will just keep pneumonia in mind. So only worry for me is pneumonia with low-grade fever and a localization at this stage. Next slide, beta. So here, dull note would tell me that there is no air in some part of the chest, especially inframammary and infraaxillary region on the right side. Now here I'm getting a localization, and when you get a localization like this, I was tempted. Please let me be honest, for an atypical pneumonia. Obviously, I would be looking for a pleural effusion or things like that. But increased VFVR has literally taken me little onto the back seat. And in auscultation also, only bronchial breathing is heard. You see, in pleural effusion also, you may hear a bit of bronchial breathing above the level of effusion, but you don't see through and through bronchial breathing. And if I see through and through bronchial breathing and diminished air entry, I am just coming to somewhere, airways are patent, and then there is narrowing. So this can happen something like a compression effect. There is, because there is localization, I'm suspecting. Please understand my point. Now I have got a dull note. That means I have to, either because of fluid, space occupying, or some mass effect, I have to see there. Or pneumonia only. Let me keep pneumonia also in mind. Now, if you keep pneumonia, diminished air entry, infraaxillary, all these are fine. If I have, let's say, right midzone, right mid-lobe pneumonia, which is probable from all these findings, I am fine. But the symptoms are not with me. Like I don't want to repeat the entire history which we have discussed now. But still, I should not go for any rare causes. That is my first line. But if this pneumonia misbehaves as per my calculation, I keep my mind open at this stage. You go next, beta. Other systems are not contributory. And I think, go to the next slide. Let's not discuss what is not required. Let's focus on the pathology. So you are fantastic as far as this summary, right middle of consolidation. But given that if you say right middle of consolidation in a 16-year-old, it comes to me strep pneumonia. And that symptoms are not matching. I agree with pain, abdomen, vomiting, headache, and these features can be there in strep pneumonia infections. But low-grade fever is something. Unless they're having poor information, pre-treated with antibiotics, partially resolving, all these are little bit sometimes happen in life. We can't expect a patient to be walking with textbook descriptions. They are still common and they should not be ruled out just because of this atypia, which I am trying to tell you, the disproportionateness. If there is no treatment or modification of the symptoms, then we have to value the symptoms and the presentation and then give some kind of explanation. At this stage, I'm fair enough to think of middle of consolidation, because that's quite common. Given the caveats that I have told you, Renka, you can proceed.
Summary, Master M, 16-year-old, previously well adolescent boy, presented with short duration of fever, cough, headache and vomiting, and on examination found to have features of right middle lobe consolidation. The probable diagnosis is community acquired pneumonia with no features of respiratory distress or respiratory failure. Coming to investigations, complete blood count showed hemoglobin of 14 gram per deciliter with a total count of 18,000 with polymorphic predominance of 77% with normal platelet count. Here CRP was highly elevated, which is 143 mg per deciliter, and we have sent 2 blood cultures each containing 10 ml for aerobic cultures, which turned out to be negative after 48 hours of incubation.
So only point here is that there is no anemia, which sometimes, hematological manifestation of an atypical organism. Now, therefore, here, unfortunately, it's coming back to typical side. Are you getting the point? No, sweetly, this with every slide, this case is moving this way or that way. Now you can see here that it is predominantly looking like an acute infection from all probabilities, unlike the atypical ones that we are thinking. So those symptoms may come back little somewhere later, I don't know. But there is definite evidence of infection from the point of view of general non-specific tests. These are non-specific tests. So they are important, but they're not all that important. But let's keep them in mind. Please proceed.
Dr. Subramania, can I just have a couple of queries addressed at this point?
Please ask.
We keep traditionally teaching that we should be looking at blood cultures, but what is the practical utility of a blood culture in a child who comes with a community-acquired pneumonia, sir?
Okay,
with the advent of multiplex PCR, what happens in the peripheries is, because most of these people are not unwell enough to have a low respiratory secretion done, they get their throat swabbed and we have a multiplex PCR report showing Streptococcus pneumoniae, Moraxella catarrhalis, sometimes also with adenovirus. Question is, in the absence of a bacteremia, what is the actual diagnostic yield for blood cultures? Because each blood culture, at least in our hospital, costs, this investigation alone will cost 2,000 rupees. Whether it is worth the money.
I'll answer both the questions. But let me give some background for all the audience who are watching. Dr. Ashwath, I should compliment you for this nice question, which even I had few days back, I would say a few years back. Now, I will give you the statistical evidence. Blood culture will only pick up bacteremia. It will not pick up pneumonia. So, so pneumonias can be bacteremic and non-bacteremic. So, evidence of bacteremia in a pneumonia is to the tune of 15% in strep pneumonia. Evidence of bacteremia in a staphylococcal pneumonia is almost zero. You don't get any. If you get, the coagulation negative staph and all that, you just ignore those reports. So therefore, you don't get a staphylococcal bacteremia, which is quite a common cause of pneumonia, as well as complicated pneumonia when you want actually some organism to answer to you, when it is running a course which is not to your expectations. The other organisms like Moraxella and couple of them which we speak out, they are not that blood culture friendly. Now, if you take the age as the criteria, then bacteremia is more likely in infancy, more so below 3 months of age, and obviously the blood culture yields more, especially neonatal and postnatal age group. But at the age of 16, I am not for anybody even doing blood culture at all. Now, if you look at the evidence-based medicine and how we try to get into the etiology of pneumonia, into the bugs, is the only thing that is consistent is direct lung puncture and isolate and put it on the culture. This is hazardous, not ethical, and not to be done at all. It's only theoretical discussion. But even in sinusitis, the puncture and culture, lung puncture and culture, pus puncture and culture. But the point is that it is not at all recommended and should not be done. Therefore, the evidence for the bugs will come from either sputum, which should not be from Here, I would say sputum culture is better than blood culture because we have a productive sputum in this patient. That's a very good thing to do rather than trying to do. But you should not get oropharyngeal flora. Should have a good technique. And 16 years is a good boy who can be educated how to bring out the sputum. You can even induce and bring the sputum. There is nothing wrong. But examination on Gram-Stein and culture would give me some evidence. But again, it does not necessarily always correlate well. But no throat swab at this stage because throat examination was essentially normal. I think blood culture negativity, I think we should get out of the blood culture mindset, especially for treating community-acquired pneumonia, except in ICU situations where you have bacteremia because of intensive care situations, nosocomial infections, catheters, this, that, etc., or because of suppression of the immunity, you will have bacteremic situations and those organisms, and otherwise blood culture is going down in the armamentarium of community-acquired pneumonia in day-to-day practice. Coming back to PCR, the problem of the PCR is the problem of plenty. That means when you take out something and microscopic DNA or RNA and make it macroscopic, that is what is polymerization and chain reaction. You make a microscopic nucleic acid, a macroscopic nucleic acid for analysis. The problem here is that problem of plenty, I mean to say, when you pick up small, you don't know where you pick up many things. They may or may not be the causes. Like if you see biofire reports, you will see more than 1 or 2 viruses, more than 1 or 2 organisms coming in your report. So therefore, we should be very, very careful in interpretation of them. Especially, these are very excellent tools for epidemiological diagnosis. When they don't do well, epidemiological, especially outbreaks, they are very helpful and it's a very good research tool. And it's also useful for making antibiotic policies now and then. And, in some of the, I would say, troublesome viral infections, when, you are not sure of an RSV, bronchiolitis, and, you have an atypical course, or you have interstitial presentations and you are in trouble in some situations, but not again in day-to-day practice. I think I made these 2 messages clear on PCR and blood culture. Darasami sir, is that okay? Because I can go on and on. Because let us come back to the case. Here, sure, so therefore, negative culture doesn't mean anything to me.
Okay, sir. Point taken. Thank you, sir. Dr. Renuka, you can proceed.
We done a chest X-ray IAP view, which showed an obscured right cardiac chill-out and right cardiophrenic angle. And there is trachea appears to be in trachea in midline. There is no mediastinal shift. And bilateral costophrenic angles were free. There is no evidence of effusion. So we made a clinico-radiological diagnosis of right middle lobe pneumonia.
Dr. Kannan, do you want to add anything at this point of time, sir? Would you be able to guide us on how to read a chest X-ray or look for subtle pointers as to etiological clues?
Yes, sir. This actually that there is a opacity in the adjacent to the paracardiac area. So it's indirectly indicate there is a middle lobe collapse. We will proceed with this, sir.
Sir, I have got a couple of points at this X-ray. Can I come in, Kannan sir?
Please, yes, please.
If we have a right mid-zone shadow and is not silhouetting the right cardiac border, I am worried. Then I'm sorry for the classical presentation. What I meant was, if it is the medial segment of the middle lobe, like pneumonia that we are thinking, let us come back to the case that we are thinking. I'm not looking like a radiologist, as a clinician. So if there is no silhouetting, that means to say it should be posterior or not anterior. Now, the point is that the clinical findings are anterior in the right, in infraaxillary,
intramammary,
as well as intramammary. I have got dullness. And I have got a shadow that is not silhouetting the right cardiac border. Right here, even before proceeding to the next part of the presentation, I have got that this particular shadow is probably not pneumonia. I'm sorry at this stage, but probably I would say yes for pneumonia given low-grade fever and a paracardiac shadow, not silhouetting the cardiac border, but having a small X-ray finding, but a very good clinical finding. If somebody can pick up a dullness, but on an X-ray it is not supporting, that means to say this is something which is tricky for me at this stage. Kannan, I think you would agree with me.
Yes, sir. That silhouetting is actually, if that is two structures should be in the same plan. So that if we are taking the heart is in the middle mediastinum. So if it is obscured, we take it as a middle lobe. If it is not obscured, it
Then
can
we'll
be
not take it.
anterior or it's a posterior. So
Okay.
it can be
I'll come further. I'm sorry for taking clinico-radiological correlation. So Renuka said that there is bronchial breathing. And if I take bronchial breathing and absence of air bronchogram in the consolidation, then again, I'm sorry for going negatively on these two findings, but negativity does not make any conclusion positive. But however, I'm worried if there is no air bronchogram sign, but a bronchial breathing, again, I'm looking at some kind of lesion which would have a bronchial breathing, but not air bronchogram. And I'm looking at a lesion which is there pericardiac, but not silhouetting. And probably it is not that around the lesion there is anything that is clue. These is also important from the X-ray for me. For example, around the lesion there is no mass effect. Everything is fine. And bilaterally the chest X-ray appears normal. Clinically, there is a lot of localization on the right side. The X-ray is not matching with the Dr. Renuka's findings of clinical findings. This is important for me.
Yes, sir. One subtle finding, but I am not sure. But compare with this lucency, compare with left side, here somewhat more dark. So every points towards right side. This lung is more dark. That is the only worry for me. Here, there is some patchy consolidation is there, some patchy opacity is there. Here some maybe some lines are going. It can be the bronchograms, but every clinical finding is going towards the right side. The only thing is compare with this area of, if you take this mid and lower zone opacity, this is more darker than this side. This is the one
Okay,
finding.
I'll come back to the I'll again come back to this. This is CPC, but this is becoming clinico-radiological correlation than clinico-pathological correlation. Kanan, it is nice to have a debate with you. And if you look at the separativeness or wet cough, and again I'm coming back to wet cough, this chest X-ray findings. I was trying to look for what about the airways? Airways appear pretty fine from trachea up to the carina. Angle of carina is normal, and I'm not seeing any nodes. At least correct me if I'm wrong. Why I'm trying to tell you this point is because even though it is uncommon, this somewhere when a chest X-ray is obviously done, a clinician should at least shrewdly look into any adenopathies that are present. These are very, very important things that one should not miss. Although I was of the impression that what X-ray doesn't show is more important than what X-ray shows. If you take that way, I think we have a lot of findings on the X-ray, but there's only one positive finding, but the negative findings against the symptoms that we have got mean a lot for me at this stage.
Yes, sir. The trachea up to carina is normal. That notes are important findings, sir. Very important. The no nodes, no lymphadenopathy. When we took here, it's important findings. So no significant lymphadenopathy is there.
Yeah.
Can we proceed, sir?
Yeah, please.
So as an initial treatment, we have started on injection amoxicillin 25 mg per kg per dose 8th hourly and oral zinc, paracetamol and face mask oxygen support in view of tachypnea.
Dr. Subramania, can I pause here for a couple of minutes because it's one of the most controversial topics on what is the antibiotic of choice to give an inpatient, especially adolescent child, where the clinical history, the radiology, and the CRP of 164 and leukocytosis with polymorphs is not correlating with the acute history, at least on radiology. We are seeing the national treatment guidelines as well as the 2024 guidelines talk about IV ampicillin as the drug of choice. Whereas when we talk about community OP practice management, the choices between amoxicillin and then cefuroxime, and then if it's an atypical organism, we are supposed to consider using a macrolide. Now, first of all, why should there be a difference between outpatient management, oral amoxicillin, and suddenly we shift to IV ampicillin for inpatient use? Can you please clarify, sir?
No, you are putting me in fix because the persons who have decided on ampicillin are someone different. I would have just put injectable amoxicillin if the orally not acceptable, and that's fair enough. But only because of lack, cost factors or couple of things like that. Between ampicillin and amoxicillin, there is hardly any pharmacokinetic and pharmacological difference, except for that the ampicillin has to be given probably 6th hourly, and amoxicillin
Yes,
can
sir.
be given little infrequently. And sometimes, gastrointestinal side effects are little plus and minus in comparison when we take amoxicillin, amoxiclav, and ampi. The only problem with ampicillin is that you don't have a clav to add, but you have to go for other additions. Now, looking at the pros and cons of ampicillin, ampicillin is one drug which is wonderful, both oral, parenteral, and can be a switchover drug. So, therefore, when you want to give orally, amoxicillin is widely available and we can give. But I'm against those who give upfront amoxiclav unless there are specific indications. Indications for amoxiclav are prior use of amoxicillin in the past 1 month or 15 days, or anticipation of resistance, or anticipation of staphylococcal or moraxella infections. Otherwise, you should be giving plain amoxicillin. Amoxicillin should be in the doses of 40 milligram per kg in our country, facing the intermediate kind of resistance, unless you have evidence to say I want to go to 60 to 80 milligram per kg higher dose. Now, coming back to your question on ampicillin, with the guidelines look at the availability and the cost, and when they make the guidelines, they will have to make the guidelines starting from the periphery to the central institutes, and it should be applicable wide across. And probably in that context, they must, instead of writing injection amoxicillin, they must have considered injection ampicillin. Considering the spectrum, both are more or less same.
Okay, sir.
Is that okay, or any other?
No, it's fine, sir. I just wanted to know whether you are comfortable with us using amoxicillin.
No, I'm fine. But only my problem here is that if you ask me individually what I would have done for this child after admitting Dr. Renuka preferred to choose to give injectable amoxicillin, I would have in the presence of wet cough, I would have gone for ceftriaxone beta. I'm sorry. I don't know whether others would agree with me. Having got a child which is having a localization, you understand, and admitting the child and putting the child on oxygen, and having a finding on an X-ray and holding on to only injectable amoxicillin, injectable ceftriaxone would be even cheaper than injectable amoxicillin for me. But I'm okay. It doesn't matter between amoxicillin and ceftriaxone. There is nothing much to debate. That's fine, fair enough. But I think Dr. Ashwath, you would also take that point. Fair enough if you choose that. Now, only my question is, can I choose quinolines? Answer is no at this stage, because TB we don't know. Can I give drugs like levofloxacin and things like that orally and manage? Answer is no. Why I'm coming to this mindset is because if you take the age of 16 years, you should keep your mind open.
Okay,
okay, Renuka, you can proceed.
Yes.
What about comoxiclav and its anti-tuberculous activities here? When you are talking about cervical lymphadenopathy, the IAP comes down very heavily on use of comoxiclav and linezolid against in bacterial lymphadenitis in the neck, because it can sometimes interfere with its anti-tuberculous action. It's one of the reserved drugs. But when it comes to pneumonia, why can't we follow the same guidelines? Why is comoxiclav preferred?
Now, I wanted to tell you that tuberculosis is a bacteria, and every antibiotic has got anti-tubercular action, including penicillin, including ampicillin, including amoxicillin. Every drug will have antitubercular action. But is that antitubercular action sufficient enough to be an qualifying an antitubercular drug? Answer is no. The MIC levels that are required for tuberculosis may be high, and the way in which the tuberculosis multiplies, rapid multiplies, slow multiplies, etc., doesn't make it a beautiful, that much an ideal antitubercular drug. So the antitubercular drugs is a range. What we are trying to look is if there is a increasing resistance to rifampicin, we wanted to have as many drugs under reserve as possible. So therefore, we are exploring multiple drugs to be under the reserve category, and therefore we are looking at which are the drugs that are used, abused, and misused. So we wanted to have a little bit of broader breathing space as far as the choice of anti-tubercular antibiotics. And therefore, we'll try to cut down until and unless required. Don't go on choosing A, B, C, D when either A or B would work. And if B has a little bit better antitubercular action than A. This is the point. Linezolid and even azithromycin have got, and levofloxacin have got antitubercular actions. And why we should use them in acute infections when you have an alternative? That is the logic. It is not that we want to discourage them from use.
Fine, sir.
Yeah,
Point taken.
please proceed.
So after 72 hours of IV amoxicillin, still he had a persisting fever spikes and other constitutional symptoms. There is no change in physical finding and there is no improvement in respiratory status.
Now, at this stage, I would have given azithromycin beta because considering the background, at least I don't think I would be guilty of, if I'll be guilty if I add azithromycin, but addition of antibiotics is not the answer. Why he is not responding should be explored. But while we add, we should also find out the reason for non-response. We can't just sleep over just by adding azithromycin. Am I clear? Whenever there is no response, the clinician should first check the diagnosis, check the drug, check the device, check the injections, whether they have given, whether they have actually taken, whether it is only on paper, whether the drugs are spurious. Starting from there, you should go for all kinds of checklist. But one of the very good option that I was choosing is one, revise your diagnosis. Number two, add azithromycin. At this stage, if the fever continues.
Proceed now.
So we suspected a complicated pneumonia. So we proceeded with ultrasound chest, which showed right lower lobe collapse and consolidation, and there is no evidence of effusion. And we also repeated CRP, which was in increasing trend. Initially, it was 143. Now it increased to 174. So we escalated the antibiotic to ceftriaxone.
No,
can we take a pause, sir?
No,
yes,
Kannan will come in, but I will just wanted to tell you at this stage that if you get a collapse in a pneumonia in a 16-year-old, let's say, the point is that why there is a collapse. That's where we would probably get the diagnosis. You have got a collapse. The cause of the collapse is the cause of the entire story of the patient. Second thing is there is a progression. That means there is no resolution of the disease because probably distal to the collapse, the whatever lesion is there is not responding to antibiotic. This is what I'm looking at. Or the cause of collapse itself could be the cause of the whole story. These are the two things. Now that there is no effusion, I'm happy. Now a little bit I'm taking out from the point of view of atypical, which I was looking at. You understand? Now I'll totally withdraw my case of the atypical pneumonias which was going on. Now I'll be focusing on collapse, consolidation, and not responding to primary therapy with amoxicillin. These are my takes. So therefore, I would revise my diagnosis, then step up with azithromycin, which I was there in the previous slide.
So there are two questions at this point. Should we be looking at ultrasound chest as a replacement to X-ray chest? Should we be doing ultrasounds routinely as a primary method of investigation rather than use it as a method for looking for pleural effusion or complications? What is the role of ultrasound as a primary diagnostic modality?
I will tell you 1, 2, 3, 4, 5 quickly, because I don't know how long we can go on this Zoom, but I will quickly go through ultrasound. Point number 1, ultrasound of the lung is the easiest ultrasound to learn for the pediatricians. To learn an antenatal ultrasound is difficult. to learn an ultrasound of the soft tissues, thyroids, cysts, even a neonatologist doing cranial ultrasound. Learning ultrasound of the lung is the easiest, because air is there in the lungs, and only in pathologies you will get no air, but fluid and solid. You got my point. So therefore, it is a simple mathematics. And Kannan would smile and agree with me that interpretation of ultrasound is all about interpretation of artifacts. And artifacts are normal in a normal lung, and absence of artifacts are the ones which are the causes of pathology. And maybe sometime for this part of the IAP, I would take a session on ultrasound and explain in detail what we mean by artifacts. If you see a pleural line, it is easiest to see that rules out pneumothorax. If you see a pleural line and A lines below the pleural lines, it means that you will get sequential shadows. That is fine. If you see B lines, and then if you can see air bronchogram. But for the audience who are watching, whenever you see in an X-ray, air appears black, and the bones and fluids appear white. But in an ultrasound, it is other way around. Fluid appears black, and air as well as other tissues, like let's say bones and others, they appear white. Now, if I look at this ultrasound, Kannan, I'm not trying to become a radiologist, but I'm trying to get into your area. They look at all those spots. They are the ones which are air. And can you see all that air and the surrounding that is the all those points are probably air. Kannan, correct me if I'm wrong.
Yes,
Nobody
yes.
should think that they are the mucus. By seeing repeated X-rays, we get an impression that, so that's where she was getting air bronchogram. That means that is the patent area where air is moving, and so she was getting air bronchogram. The surrounding that area, you would see little solidification. Wherever you find liver-like shadows, that means the lung is replaced by a liver type of tissue, which is consolidation. So if you look at that image of the USG, don't you feel like it looks like liver, although it is in the area of the lung? That means there is consolidation. This is all that I would look into it. And I do not know whether that on the two dark shadows on either side are the shadows of the ribs, or is it fluid? This is where I'm little confused. Kannan should help me. But this much I can do, Kannan. I cannot go further because this is only one picture. You need different views to make sure. And coming back to lastly, Ashwath sir's question, my own student did a paper, won the best paper award in the Respicon in 5 years back. Ultrasound versus chest X-ray and diagnosis of pneumonia. Ultrasound is safer, radiation free, easier, point of care can be utilized, and better than X-ray with better sensitivity and specificity than chest X-ray. And the beauty of ultrasound, while X-ray cannot be repeated, ultrasound can be repeated by you. Even next day you ask them, lie down, I will see in the probe, they will say yes. But if you tell them, go and get an X-ray done, the parents will walk out of your chamber, they will not come back. And they will expect a lot on an X-ray. But on an ultrasound, they don't expect much. This much I'm getting, let me follow it up after 6 hours, they will say even yes. And the complications like fluid, encysted effusions, or empyemas, excellently picked up on ultrasound. And there is no complexity like you see in other areas. Lung ultrasound is easiest, while the pediatrician nowadays, except for vaccination, they don't have any other source. I think they should be looking for ultrasound of the chest.
Thank you, sir. That was a delightful comment. Thank you. Dr. Kannan, do you want to add anything?
Sir, you can't get the machine, sir, without PCPNDT registration. That's why the
Kannan sir, now I am medical superintendent, I know the rules. Only radiologist and gynecologist can buy a machine. All that a pediatrician has to do is that he should just procure the machine for point of care, which he can legally do. Point of care ultrasound is allowed. But only thing is that if he is very, Dr. Ashwath and others introduced me as the person who makes some humor. If a pediatrician can't buy an ultrasound machine, he should marry a gynecologist or a radiologist.
Absolutely, sir. At least a technical collaboration.
Okay, please proceed, ma'am.
Sir, only one thing, sir, that X-ray replacement ultrasound, now the most of the studies they are comparing. In another 5 years, that ultrasound will obviously it will take over. Now we are in the stage of that learning curve stage. We are comparing with the X-rays with the ultrasound. Nowadays, the neonatal ultrasound, chest ultrasounds are very good. The neonatal, they pick up the hyaline membrane disease, pneumonias, effusions. It is very good to pick up with the neonatal ultrasound. So another 3 to 4 years, that neonatal chest X-rays will replace by the neonatal ultrasound, chest ultrasound. But the problem, yes.
Kannan, and in another 3 to 4 years, pediatricians, radiologists, and gynecologists can have ultrasound legally. Okay, continue.
Another one, sir mentioned that pediatric, that pneumonia case, the problem with ultrasound, we need to know the localizations. That X-ray obviously will give the idea where which lobe affected. So it gives the idea. Then we do the ultrasound. Okay, we will follow it up. If any fluid, any abscess comes, that complication we can pick it up. But that ultrasound, the problem is if small, like this case, that paracardiac opacity.
Yeah, definitely.
Sometimes
Kannan, I would 100%. I'm just interrupting you. I'm 100% agree. Please don't start ultrasound as a screening tool. That's what Dr. Kannan is probably trying to tell you. In that case, you have to go to each intercostal space, each area, and see the perpendicular views, intercostal view, and transverse view, and then you putting that probe pointer onto the right, and you should keep on seeing. That's most difficult. I have also been the faculty in many workshops on ultrasound of the lung. So therefore, what even today we had the workshop. The most important points for the pediatricians is learn it properly and learn it wisely, and you should know the probe. Kannan, can you just now that Dr. Ashwath has raised this point, can you quickly tell which probe to buy, high frequency, low frequency, and whether it should be the one with curvilinear type or that transverse type?
That yes, the linear probe is good for that ultrasound chest. Ultrasound chest. Yeah, there is a A line, B line, multiple lines. The pneumothorax, we can pick it up. The pleural effusion, it's very good. Even for more than the chest X-ray, it's very minimal effusion can be picked up by the ultrasound. But that pneumonia, if you once localize the lobe, and after that you can follow it up with the ultrasound. The complications you can follow it up. That's what.
Sure. So you're not recognizing that as a primary tool, but as an add-on. Once you have a good look,
and I tell you, even in radiology, I can't just right away do CT scan for everyone as a good substitute for chest X-ray. So in radiology, we got ultrasound, MRI, X-rays, and CT. No investigation is exclusive of the other. Even after CT, I have seen radiologists doing ultrasound and coming back, even if they have all the details. So therefore, each investigation should support the other investigations and must come to a logical conclusion. That's the message. That's the message.
Point taken, sir. Renuka, can you proceed, ma? We are running out of time.
So after 48 hours of ceftriaxone, still he having persisting fever spikes and he developed a hypoxia requiring oxygen support. So we suspected complications like necrotizing pneumonia, empyema, lung abscess or pneumatocyst. So IV clindamycin was added and we further proceeded with higher imaging studies.
Go ahead, ma.
So we done
Dr. Kannan, can you, for want of time, can you please quickly guide us on how to interpret these films?
Yes, sir. This actually HRCT films, the HRCT chest. This is the axial one and this is the coronal one.
Can you please clarify what is HRCT versus conventional CT? We do not know what's the difference between CT and HRCT.
That higher end machines, we usually do the HRCT means like it's a 3 mm thickness, slice thickness images, sir, usually. Now, nowadays, we are all doing that 3 mm, less than 3 mm slice only. So that is not that much makes a difference in the chest CTs. Then come to the interpretation, sir. This is the axial one and this is the coronal one. So
Can you put a pointer, please, Renuka?
yes, sir.
Dr.
This
Renuka, can you please put a pointer when he's talking? Yeah, thank you.
this the this the axial and this left side images are coronal one. This axial image, this the upper lobe, this the left upper lobe. Compare here, there is some kind of increased air lucency is in this region. So in the coronal image, we can easily see this lung field, this the lower lobe and this upper zone, the lung field in the coronal. We can easily see, compare with left side, right side is more black. So when the X-ray or the CT, if it is more black, only 3 points. That area has more air or reduced blood or reduced muscle. So the increased air means it can be due to the bronchitis or foreign body, any obstructions, any air trapping that will happen. That reduced blood flow means embolism can produce that. The reduced muscle thickness means absent pectoralis major Bolen syndrome. It can produce that. Another one interesting here, they put this image, the coronal image. There is like cut off in that right main bronchus.
Main bronchus, correct.
The cut off.
Dr. Renuka, can you put the pointer there? Yes,
Yeah,
please.
here this this like cut off is that this is actually a lung window. So we are seeing only the lung. It's very easily seen. So next we need to see in the mediastinal window. So here what is there actually? So compare with this, I obviously go for the foreign body because that is obvious in the children. That is my first one. So here the air trapping and there is a cut off in the right main bronchus.
I have got only 2 points to add for all the pediatricians. Please don't say that HRCT is better than conventional CT. In some diseases, conventional CT is better than HRCT. It's like, the modern machines, not the old machines, will you just take the CT and request the radiologist to give the HRCT films, he will give HRCT films. Conventional films, he will give conventional films. So HRCT is not a CT machine. It is a protocol. It is just that, like you say, with contrast, without contrast, like that. So it is just that the parenchyma is seen well. And, if you see the parenchyma outline and all, that is the HRCT film. In conventional CT, you may not see them, but that's good enough. It is not necessary that you should ask for a HRCT or a conventional CT. Please call Dr. Kannan before you order. He will tell you whether in that particular clinical context, whether we should go for HRCT or conventional. Don't write straight away an order and send. He cannot displease any clinician. Sir, some senior Dr. Ashwath sir has asked HRCT, how can I do plain CT? So it becomes very embarrassing for Kannan. So I'm just taking your names for the benefit of everyone. So please don't put them in fix. Please discuss with them before you order.
Dr. Kannan, can you guide us through these 3 films, please?
Yeah, this is the post-contrast axial images. This is actually the mediastinal window. Like you can see all the soft tissue structure. So this is the arterial phase. So here the pulmonary artery is filling. Here that cut-off region. So here the bronchus. Here the well-defined lesion is here. It shows enhancing. So there is a endobronchial intralumen lesion, a well-defined lesion, no calcification. It shows enhancement. And here that venous and delayed phase, it shows washout. Yeah, because the foreign body won't show the enhancement. So here the enhancing lesion in the endobronchial location. So in the pediatric age group, it's a benign and malignant. So it can be endobronchial adenomas or a bronchial carcinoid or inflammatory myofibroblastic tumors or papillomas can be there. Sometimes the mucoepidermoid carcinoma or sometimes the endobronchial TBs can be there. But the thing is, there is a lesion in the intralumen. It shows enhancement.
So you are saying foreign body is unlikely because it is enhancing after the administration of contrast. Can we interpret it that way, Dr. Kannan?
Yes, sir.
Renuka, can you show the pointer? Where exactly is that?
Yeah, that is.
Correct.
Yeah.
Sir,
Fine.
only one doubt I have, sir. For as
Please.
per sir, usually that like that we suspect the foreign body, we do the blind CT, but how you suspect and order the contrast CT? That is my interesting question. Usually we do with the blinds for especially.
No, primarily because of the presentation of the child. He is 16-year-old, well-built fellow, acute onset of history with mucopurulent sputum. Very, very unusual to have a foreign body in this age group. That was the reason.
The
And he
age
had
group.
high spiking fever with high CRP. This is not the age at which we will think of foreign bodies unless he is aspirated a button battery.
Okay,
That is
okay.
also very far-fetched. That was the reason why we asked.
Okay, I understand. Okay.
And secondly, sir,
Can we
if you have any lesion in the right middle lobe, you should not keep the foreign body out of the discussion, no matter whatever may be the age. Although it is unlikely from my side also, but in right main bronchus, if you have a lesion, that should come to pediatrician first in the mind. Maybe even for the adult physicians, you will never know.
Sure, sir. Point taken. Can we move on, sir? Can we move on, sir? Subramania, sir, can we move on?
Yes, please, please.
Dr. Renuka. So we can watch through this. This point has been discussed. We are running out of time, so we can go to the next slide.
So we further proceeded with the bronchoscopy, which showed an soft tissue lesion in endobronchial soft tissue lesion in the right main bronchus, which is near completely obstructing the right mainstem bronchus. And also there is a purulent secretion noted in the right lower lobe bronchus. Can we move?
Okay. Yeah, I think what is important here at this stage is let's go back to symptoms. We got the reason for wet cough. We got the reason for localization. We got correlation with the CT. We got a lesion. Now the question is, does it appear like hemangioma or anything? Because the bronchoscopist not only will visualize them, they will also they will touch and move, pedunculated, or is it obstructing, is it sharp, description, findings, and the history is very acute of 4 or 5 days duration. So I would be going in more favor of an endobronchial mass lesion, which is probably benign or malignant. And given the sharp rise in the symptoms, and the symptoms that we have got in this patient is not because of the lesion, probably it is because of symptoms of obstruction, like symptoms of diminished air entry, dullness, wet sputum. They're all because of the evidence of obstruction. I think I'm making it simplified just for the pediatricians from first slide till now. They can correlate well now. Only I was worried about the pediatrician should examine for evidences of hemangiomas and benign lesions elsewhere, ask for some family history of malignancies. I mean, these are some of the checklists that we can go through. But generally now, I think we need to get a biopsy or excision, and I think that's where histopathology or local diagnosis will be made. At this stage, without getting a tissue diagnosis, we can't get away just by reducing the mass effect. This is my approach.
Sure, sir. Can you proceed, ma'am? That's exactly what we did, sir.
So we proceeded with endobronchial ultrasound guided needle and forceps biopsy, and specimen was sent for cytology, histopathological examination, and immunohistochemistry. And bronchoalveolar lavage sample from the right lower lobe bronchus sent for gram stain, AFP stain, gene export, culture sensitivity, and multiplex PCR for respiratory panel. In a bronchoalveolar lavage, gram stain, AFP, culture, and gene expert all turn out to be negative, and multiplex PCR was positive for Haemophilus influenza and adenovirus.
Now, don't ask me the interpretation of PCR. We'll move on. Now, I explained how the PCRs will create problems to us. Now, can we get, there is a beautiful, I think I will sometime write up an article. I'm in the process of respiratory microbiota. I mean, what are all the organisms that can be existing from nose to alveoli? commensal or pathogen or mixed behavior. So somewhere this is an area of interest, and somewhere down the line in another 3 or 4 months, I'll complete that work. Please give me some time. But at this stage, if you get multiple organisms isolated from multiple places, please go ahead slowly clinically. Let me give some clarity in the subsequent sessions or in the subsequent journal or somewhere. Sir, with lot of admission, I'm telling, it's very difficult, Dr. Ashwath, sir.
Okay. So can we disregard that H influenza, or do we think that that is the reason why
No,
the child is not?
H influenza and adenovirus, I think we should just keep it aside. Probably they may be the organisms that are causing infections distal to the obstruction. Possible. Any organism can cause obstruction. But age-wise for H influenza, for this, I don't know, adenovirus, whether either of them is a pathogen, and can I have a bacterial as well as adenovirus plus H influenza as a combination? This is something which is tricky, and I don't have answers, sir. And I accept the point. Anybody else in the group can even put it in the chat box. I will continue the discussion in the chat box for that point. While for want of time, you can proceed with this.
Okay.
Please discuss in the chat box for that H flu plus adenovirus combination.
Dr. Renuka, you can proceed.
Yes. On 10th day of admission, he became clinically better and fever spike started to settle. So he got discharged home with oral cefpodoxime, oral clindamycin with awaited biopsy report.
At this point of time, I'd invite Dr. Rajeshwari, a consultant pathologist, to walk us through the case scenario.
Yes, sir. So, we got the biopsies with a history saying that there is a endobronchial luminal lesion. So before we get a slide, we'll have a broad differential. Could it be an infective etiology, or could it be an inflammatory, or could it be a tumor? So these are the major differentials we used to have when we have an endobronchial biopsy. In the infection, we have to first rule out the endobronchial tuberculosis and histoplasma. So we have to look for any granuloma organism. And is it a granulation kind of a polyp, or it can be a primary or a metastatic tumor of that site. This is a broad classification, broad thinking we have to have before looking at the slide. Next, ma'am. Yeah, these are the tissue biopsies which you have received. One on which the Renuka is pointing. This is the scanner view of the tissue. Whatever you could see in orange are the cores of blood clot, and in between you could see a few bluish dots like tissue fragments. And while the next part, there's a low power view of 10x. This is the fragment of tumor which we could see here. So we have ruled out there is no granuloma in this. So we have ruled out an infective pathology. There is no granulation, but we are seeing here some kind of a cells which is forming a cluster. Next slide, ma'am. Yeah, these two are the higher power views of the same cells. Here we could see these clusters of cells are not forming any pattern. There is no glandular pattern formation, or it is predominantly like a cluster and sheet. And these cells looks predominantly monomorphic. Whatever you could see in pink are all the cytoplasm of the cells, which is really abundant and is granular. And the nuclei, which is stained blue, are all looking homogeneous and dark. There is no mitosis in this slide. Mitosis will look like a caterpillar easy to understand. Here, we are not seeing any kind of a mitosis, and there is no necrosis of this tumor tissue, whichever we have received. So with this morphology, which is having this, whichever the Renuka is pointing is looking little plasmacytoid, which we think about our learning in MBBS, the plasmacytoid cells. That means the nucleus is pushed to the periphery, and the cytoplasm is seen abundant. This is how it looks like. And here, so with this morphology, I would consider a neuroendocrine neoplasm would have been the ideal differential here. Next slide. So this is the report which we have released, saying that it is suggestive of a neuroendocrine neoplasm, which is from the endoluminal mass and also from the needle aspiration core. Any queries, sir?
Madam, is carcinoids same as neuroendocrine neoplasms?
Sir, I have broadly put as neuroendocrine neoplasm because we need a confirmation. Nowadays, we need a confirmation of the lineage of the cell. before saying it as carcinoid, because sometimes we may think now with this morphology, this is looking like a carcinoid. Sometimes it gives a huge surprise. It's a Pandora box. So we are playing it safely.
No, I'm a clinician. I'm going back. Now looking at some of the symptoms, I typed in the chat box also, looking like headache, vomiting, some symptoms which are not explained by the presentation of just that infection part which we were looking at. Probably I was looking at some of the symptoms because of that neuroendocrine type of presentation.
Exactly, sir.
And probably I think as clinicians we should not be just stopping there and then referring. You should come back to the history, because again in the next history we should come back to this neuroendocrine tumor. We should not miss it again. If we learn from today, we should not miss it again in our life. So somewhere that symptoms, were like disproportionate, or they were as apparent or as brighter as even the wet sputum. These symptoms, headaches, they were all very specific, and there's negativity, a lot of negativity about it. So that kind of, I was surprised that flushing and other things are not there, probably because of color of skin, and they could not make it out.
Yes, a neuroendocrine tumor actually is a broad terminology which includes the carcinoid and the neuroendocrine carcinoma. So here it's a small biopsy which I have got only 2 millimeter of the tissue. So I don't have a 10 hyperfield.
I have got two queries. Do you want that bronchoscopist to also take EBUS of the lymph node? That is because even though there is no lymph node enlargement, they can be either benign or malignant, or they may be benign having malignant potential, and only metastasis, ruling out a metastasis is the only way that we can say they are benign. Probably, I'm correct me because you are an oncopathologist. Correct me if I'm
Yes, sir. Yes, sir. Yes, sir. We have to rule out metastasis only by saying that it has metastasized to the lymph node or a distant site. That is for a carcinoid. But we can say the carcinoid is a low-grade neuroendocrine tumor. If you go to the higher grade, is a small cell neuroendocrine carcinoma and the large cell neuroendocrine carcinoma, where the morphology will be clear. It will have a high-grade morphology. We'll see the necrosis. We'll see numerous mitosis, which I was looking for in the previous biopsy.
So Kannan or others can guide me. Now I think we should go for PET scan.
Yeah, so we have confirmed this diagnosis with the immunohistochemistry before that.
Okay, fair enough.
Next slide,
Yeah. Next slide. So these are the histochemistry slides. The one here, what she's pointing, the next one. Yeah, this is the one which is the neuroendocrine marker, synaptophysin. Here we could see the cytoplasmic staining in these tumor cells. So when we go deeper sections, the amount of tissue has come down. So that's the issue. Only that much of tissue we had, and it has come down, but still we could retrieve the tissue of this much, and it has stained neuroendocrine granules. And the proliferation on the other side, which is very low. We could see 3 to 4 cells in this field, which is taking the brown stain. So it is a low proliferation index tumor, which is having a neurosecretory granule positivity. So hence, next slide, ma. With this markers, we have given the final impression as carcinoid tumor, but we have not specified whether it's a typical carcinoid or an atypical carcinoid because of the size of the tissue, which we could not, it is not enough to grade as typical or atypical.
Next slide.
Serum chromogranule level seems to be normal, which is less than 100. Next slide, ma'am. So as we have already discussed with the neuroendocrine tumors, we have carcinoid on the benign side and the small cell carcinoma and large cell carcinoma, which are very rare in pediatric age group. In the carcinoid, we have two types, typical and atypical. Can you go to the next slide, ma'am? Yeah, we say typical and atypical based on 2 points. That is, the mitotic count should be less than 2 per 2 millimeter square. That is the tissue area. We have to have at least 2 millimeter square of tissue area to count the mitosis, and it should be less than 2 within that area. And there should not be any necrosis. In that case, we can call this as a typical carcinoid. But even in a small biopsy, if you see more than 2 mitosis and you have seen a necrosis, you can very well call it as atypical. So here the necrosis plays a vital role here. in making a differentiation between typical and atypical in a small biopsy sample. Otherwise, better to stop with carcinoid tumor. It be decided only on excision, sir. So these are the other common primary lung tumors which we can expect in a children with this similar kind of a picture. Either the most common among the benign one is a papilloma, which can be a squamous papilloma or a glandular papilloma. Then the pleomorphic adenoma, hamartomas, leiomyoma, chondroma, schwannoma, or any benign tumors which are normal to the tract. And coming to the intermediate group, which is most common, is the inflammatory myofibroblastic tumor. And in the malignant side, 80 to 85% of the cases are occupied by carcinoid tumor, followed by around 5 to 8% of 8% by mucoepidermal carcinoma, then rarely adenoid cystic carcinomas, then lymphoma like Hodgkin, then sarcomas like rhabdomyosarcoma, leiomyosarcoma, even we can have a granular cell tumor. I think these are the differentials among the tumors which we can consider as an endobronchial mass.
Perfect. Thanks, ma'am. That's quite an exhaustive list. Can we go to the next slide, ma'am?
How do you remember so many?
Sir, it is just a broad classification for us, sir. Like we see like that.
So every time you get into all this, because my wife is also a professor of pathology, but I couldn't discuss this case with her. Therefore, I always wonder.
No, sir, the morphology, sir. It's all morphology, sir. When you look at the cell will talk to you. That's how we converse with the cells.
I envy both radiologists and pathologists for the reason that for us 1 to 18 years is only so difficult. But how can you go from 1 to 100 years and then all across all the specialties? I mean, really, I think the two are the invitees, radiologists as well as pathologists. Nowadays, they're putting probe everywhere and taking scans every here and there. So much of anatomy, so much of morphology and pathology. I think kudos to both of you for not for this case alone, but for many exemplary diagnoses that you are making. Thank you so much.
Thank you so much, sir.
Now, okay, we are coming back to the question of PET scan. So, Renuka?
Yes. So after confirming the diagnosis of carcinoid tumor, we proceeded with radionucleotide scan, which is gadolinium-68 DOTATAC, which is basically a octreotide scan. Because most of the carcinoid tumor will have a somatostatin receptor. So we will proceeded with this scan to look for metastasis elsewhere in the body. Here there is increased tracer uptake in the right main.
Dr. Renuka, DOTATOC for the uninitiated is an agent which will bind to the somatostatin receptor. Carcinoid tumors, nearly 80% of them will have somatostatin receptor. DOTATOC will behave like somatostatin and go and bind to the receptor. So wherever there is a somatostatin receptor bearing tumor cell, the gallium-68 will glow. That is the principle of doing the DOTATOC. Just remember the last OC of DOTATOC. OC stands for octreotide, which all of us know to be a somatostatin analog. Okay, ma'am, proceed.
Here there is
Dr. Kannan?
Yes, sir. Only one point, sir. Madam mentioned like the typical and atypical carcinoids. So the typical carcinoids that have that somatostatin receptors more. So it will bind in that this like this. It will bind and it will emit that radio tracer, the gallium. But if it is a poorly differentiated one, it won't take somatostatin. That time we need to do the FTG PET. So that is why that pathology is important. It's a typical carcinoid or atypical carcinoid. The atypical carcinoid include that poorly differentiated one and the large cell carcinoid. If it is a typical one, we need to proceed with TOTATAC. If it is a atypical or poorly differentiated,
FTG PET.
go for FTG PET, we need to go for staging.
Very, very important point. Thank you, sir. Dr. Renuka, you can continue, ma'am.
Here there is no evidence of somatostatin receptor uptake elsewhere in the body. So there is no evidence of metastasis. So the child underwent robotic right mainstem bronchus sleeve resection along with secondary carinal reconstruction with total lung parenchymal preservation. On follow-up, he is thriving well.
So we have
Now,
come to the end of the presentation, sir.
but
So can we-
before we would conclude, I think we should compliment Dr. Ashwath. You are handling this patient, I suppose. I don't
Yes,
know
sir.
who, a primary pediatrician, but how could you convince so many investigations and intervention for somebody who comes with fever of 4 days and headache and vomiting, which every one of us see in our day-to-day practice from that X-ray and going up to here? It's exemplary. I understand the efforts of Dr. Kannan and Rajeshwari in picking up when you have given them. But the pediatrician who made that suspicion, no, that we should get somewhere there was fantastic. And I think looking at 4 days and working up, if somebody has a symptom of 3 or 4 weeks, they will surrender. But to convince a mother of 3 or 4 days symptoms and just some wheeze in the past, hats off to you. And I
That is
don't think
Ashwath.
anybody else, but for you, should receive the applause for a real life situation where I can imagine you in front of that patient talking to that mother for a CT itself is something adorable. We can all discuss and be the champions on the webinar, but you are the real life champion for all of us. I'm sorry, but I'm so
Well said, well said. Really, I
No, sir.
agree
I
with that.
think I
Yeah.
think that is the bulldog attitude of pediatric training mentored by Dr. Professor Srinivasan. Never rest till you get to the diagnosis. There were lots of atypical features in this child, and the parents were also exemplary. I think Guru Purnima, we keep complimenting each other. Our biggest teachers are our patients. So I think willing parents and patients who trust us implicitly, I think when we are conscious of the fact that we are doing something good for the child, and we talk and convince them, I think they can understand the gravity of the situation, sir. I am personally thankful to my parents and the child's parents for having given us a free hand to work up the child to the logical conclusion and get to the diagnosis. So big thanks to them, sir. And thank you for your words of encouragement.
Sir,
only, sir,
Sir?
for want of time, I will only tell
Sir?
only 2 lines from my side. Whenever you see any case in the day-to-day practice, if they fit into textbook descriptions, you should not relax. If they don't fit into textbook description also, then also should not relax. So therefore, never take any case as the first case, last case, and you will have to bite yourself. Oh my God, I missed it. So never ever relax. Some cases give you the answer upfront. Some cases give you the answer over a period of time, but you need the patience. These are the words from my side as a conclusion for this case. Sir, Balshankar sir, over to you.
Yes, sir. I second you, sir. This is a wonderful workup by Dr. Ashwath and team. I appreciate Dr. Ashwath and the radiologist, pathologist, everybody who has done a remarkable job in bringing out such a wonderful diagnosis in a child with just a fever of 4 days duration, cough of 4 or 5 days duration. It's a remarkable work I have done. Thank you very much. And people might wonder how far this carcinoid is common. Of course, carcinoid tumor is known to occur in the gut anywhere from the stomach to the rectum. But how far it is common to occur in the lungs? Yes, the second most common place for carcinoid is the lung. That's what the books say. And we can wonder how far this carcinoid in the lung is common in children. Actually, it is supposed to be one of the most important primary tumors that occurs in children, carcinoid tumor. So it is not that rare problem to occur. A carcinoid in the lung is not that rare problem. And the second thing that will come to our majority of the people's mind is whenever we say carcinoid, we think of carcinoid syndrome, where you get this flushing, redness, itching, edema, and all those things. It has not occurred in this child. So we should remember that in children, the carcinoid is very silent. But in adults only, it is common to get this carcinoid syndrome typically. So these things, if you remember these things, we will accept that this diagnosis is a very good diagnosis in a child. These are some points I wanted to add. Thank you very much, sir.
Can I make a
And I would
statement?
also, sure, sir, please.
Yeah. The fact that with one flushing and this thing itself, so much of work has been done instead of repeated attacks. Then, of course, you may think of carcinoid. That is the greatness of the clinician who has done everything. The first admission itself. instead of going for the second, third admission, etc. So I appreciate Ashwath and his team for an excellent this thing. Thank you.
Dr. Venugopal was the pulmonologist involved in the endoscopic bronchial ultrasound, and I have to place my thanks to him for being very, very supportive. And I once again thank Professor Subramaniam for taking time off from his schedule and being so patient, analyzing symptom by symptom. I mean, it is mind-boggling, sir.
Sir, only question I wanted to ask our pathologist, Dr. Rajeshwari Madam, how often, if you, let's say I was the bronchoscopist in that time, how often I should try to, take a cut biopsy and know that it is vascular, not vascular, suppose if it bleeds in, you understand, we should see and come back, or we should punch and come back. This dilemma is there for the bronchoscopist. Rajeshwari Madam, now that you are an oncopathologist, please tell us. Should we punch no matter whatever it is?
No problem, sir. Sir, actually, we have a good ROSE team here. That is the rapid on-site assessment examination of the slides, which they do when they're doing a bronchoscopy. So we have a connectivity from the bronchoscopy room to the pathologist. So we'll be watching it. So they'll make a smear and we'll say that they are in the lesion proper, and they will send the tissue.
So it's almost like that frozen biopsy kind of
exactly,
approach.
sir. So we'll be giving the cytology immediately, that you have we'll tell the adequacy of the sample by cytology smears. Then they will take a punch biopsy.
Last question from the point of view of patient care. Will you also give them some directions as to whether they could get something from the margin, or are you okay with anywhere from the lesion? How the bronchoscopy should approach? This is the last question. Sorry. Sorry for the time. Please
no problem,
me,
sir.
Dr. Ashwath.
Sir, actually, for the diagnosis, we need from the tumor proper, lesion proper.
Okay.
Then only based on what we categorize, then only you can go for an evidence-based treatment plan, like how to resect. Do you need to go for a wide resection, or just the polypectomy, or you have to go for a lobectomy? All these things depends on the type of the tumor. The histology matters a lot. So I prefer to have a proper chunk biopsy of the lesion.
Okay, Dr. Kannan, I'm coming back to you. Is that CT enough, or do you have any advances in the CT that can, will plan the surgeon for minimal resection?
We can do the virtual bronchoscopy, sir, that the lesion is how much pedangulated, how much inside the lumus, how degree is there. We can recreate it. We can recreate
no,
it.
My question is, should we also do MRI?
No need, sir. No need.
No need. Okay, fine.
No need. The only one thing I want to mention, that whenever you suspect some increased lucency, that clinicians need to ask that expiratory film, because we are not routinely seeing that X-rays. The clinicians only see the X-rays. We usually miss that. But this child, you suspect some increase, some lucency difference between the lung field. If we took the expiratory chest X-rays, it will give the clue that there is a air trapping is there. Another one is there is a difference is there in the partial obstruction and the complete obstruction. That complete obstruction will produce the collapse. Partial only produce the V's and these pneumonias, these types. So that I need to understand. Another one point is that nuclear medicine, if it is extensive metastatic carcinoid, there is another scan is that this is gallium-69 coated, that lutetium coated scan is that they can use for the treatment. It is also somatized in Anderlac, but this gallium emit the gamma rays, but there's somewhat more powerful rays like beta rays. It will emit and it will kill the cell. For metastatic carcinoid, their treatment is there also in the nuclear medicine. And I am doing only pediatric radiology here, sir. I am dealing with pediatrician day to day.
If you want to come to Bangalore, please let us know.
Fish catching.
No, I'm not fishing. Dr. Ashwath, sorry for those words. Dr. Ashwath, you can carry on. That was in a light.
I just want to end the session with my deepest appreciation of the efforts that have gone into it. Again, thanks to Professor Balashankar, Dr. Thirumurugan, Dr. Dakshani, and Dr. Murugesh Lakshmanan for making this platform available. We are indebted to our panel of experts, Dr. Subramania, Dr. Kannan, Dr. Rajeshwari, and Dr. Renuka for being patient enough with those numerous interruptions and getting quizzed again and again. And I wish all of you a good night and hope to see you in another CPC very soon. Thank you, sir. Anything
Thank you
else
very
that
much.
may
Thank
be
you,
added?
Aditi.
So my only request is that please send me links for all CPCs, be it pulmonology or otherwise. This is so interesting a platform. Balashankar sir, congratulations. I can
Thank
see
you, sir. Thank you.
Rajendran
Thank you.
sir
Thank you,
also
sir.
nodding. So we have got wonderful academicians and an excellent team. I may be a guest today, but I felt that I should have been in your IAP group. You know, maybe there is a lot of discussion that goes on. So we'll be very happy to get in and then, interact. It's so nice. Thank you so much. Thank you
Thank
so
you.
much
Thank
for
you, sir.
inviting me.
Thank
And my teacher, Dr. Srinivasan sir, thank you so much.
Thank you.
Thank you. Good night, all of you. Very
Good
nice,
night.
excellent,
Sir.
very satisfying learning experience.
Thank you, sir.
Thank you, sir.